I was going to say good afternoon, but good morning, everyone. I know we're close to afternoon. It's great to see everyone today. We will call to order the statewide substance use response working groups treatment and recovery subcommittee. So grateful that all of you could be here today. Our first item of business is to establish quorum through our roll call. So I will turn it over to Kim Hopkinson from FCI to walk us through that.
Thank you, Chair Shell. So when I call your name, if I could please ask you to indicate if you are present verbally. First, Steve Shell.
Here.
Okay. Giuseppe Mandel.
Present.
Thank you. Assemblymember Goulding.
Here.
Thank you. Assemblymember Edgeworth.
Present.
Thank you. Dave Briggs. Right. Dr. Partita Corona.
Present.
Thank you. And Stephanie Cook. Okay. Stephanie, are you on?
Yes, I'm here.
Thank you. I did see you on there. I just wanted to confirm. All right. So with that, Chair Shell, we do have quorum.
Okay, great. Thank you so much, Kim. Okay, moving on to item number 2. This is public comment for discussion only. I will turn it back to Kim to walk us through that process.
Thank you. Done. Let me see why it doesn't want to progress. There we go. All right. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment is limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you're dialing in from a telephone, dial 669-900-6833. When prompted, you'll enter the meeting ID of 865-8016-1096, and please press *6 so we can prompt you to unmute. We do ask that members of the public refrain from commenting outside the designated public comment periods unless specifically called upon by the chair. Additionally, we do ask that members of the public and other attendees do not use the chat for any communication because that is not visible to everyone who is in attendance. If, for example, they're calling in from a phone, and so that's not in alignment with open meeting law protocol. So with that, I'll open it for public comment. Or I would ask Chair Shell, are you opening it for public comment?
Yes, thank you, Kim. Yes, do we have anyone today wishing to make public comment?
Giuseppe Mandel, for the record.
Yes, Giuseppe.
Just because it is not in the agenda, so I just wanted to highlight some of the month that I've had, and just for all the members to be aware in the treatment area for adults and especially adolescents, that our state is currently at the bottom with all mental health and treatment. And just to highlight and reminder, and this is for myself included when reviewing certain things, that I do know of a few programs and a lot of conversations I've had who have moved out of the state specifically because sometimes, and I'm including myself in this, we need to be aware that, already working in established programs that are doing well, we need to be really aware when we put recommendations is that we don't interfere with how they do their programming. They're kind of the experts in the field. And when they come into our city and state and they have an already affecting program in multiple states, but we want to come in and add extra regulations or extra things or extra programming into that state, and some of those companies or organizations, Boys Town being one of them for adolescents, they they're only going to work the program that they want to work, and we need to be open-minded and listen to how those work. They did remove their program from the state, which we did not need, simply because the state wanted them to do certain things a different way, and they were not willing to change their program that's already sustainable. very successful around the United States. We can always dive into why that is and what regulations or states that the state wanted to add or therefore. But I just wanted to publicly make that comment and be mindful that we are at the bottom. So we need to be careful when we do have successful programs in the state, that we don't try to alter them as professionals because they may not fit what our state wants them to do. And they're succeeding in other states and we are at the bottom. So keep that in mind.
Thank you for that, Giuseppe. Anyone else wishing to make public comment today? Okay, that will conclude public comment. We will move on to item number 3. This is a review and approval of our minutes from our meeting held on February 24th, 2026. Hopefully our subcommittee members have had a chance to review the minutes, and if so, we can entertain a motion to approve.
Motion to approve.
Thank you, Dr. Perdita Corona. Do we have a second?
Giuseppe Mandel, second.
Thank you, Giuseppe. Is there any discussion regarding the minutes from our last meeting? Okay, hearing none. All those in favor of approving the minutes, please say aye.
Aye.
Any opposed? Motion carries unanimously. Thank you. Moving on to item number 4. This is for information discussion. Some of you may remember that in our February meeting, we brought forward a recommendation regarding contingency management that was presented by Chelsea Cheatham. And so this is a presentation by Michelle Berry, who is the executive director of CASAT, otherwise known as the Center for the Application of Substance Abuse Technologies within the School of Public Health at UNR. So we're very glad to have Michelle Berry here with us today, along with Michelle Solomon, I believe, as well. So Michelle Berry, I will turn it over to you. Thank you so much for being here.
Great, thank you. Can you hear me?
Yes, we can hear you.
Okay, great. So I did prepare a PowerPoint presentation. Oh, there it is. And then if my colleague Michelle can come off mute too, she will be assisting in this presentation. So
I am here.
okay, great. Thank you. And then Jessica Johnson from Southern Nevada Health District, too, our project officer. If she has information that she'd like to share, then we'd welcome that in the conversation too. So this is really an information item about contingency management. We were awarded a award from Southern Nevada Health District funded by Senate Bill 118 to look at training providers within Clark County on contingency management. So we facilitated a needs assessment and we'll be reviewing our results today. So next slide. The Southern Nevada Health District, in partnership with CASAT, the University of Nevada, Reno, and UCLA's Integrated Substance Use and Addiction Programs, surveyed approximately 22 agencies to better understand current awareness of contingency management and what they need to successfully implement it. And for those that are new or need a definition, contingency management is an evidence-based approach that uses positive reinforcement to encourage desired behaviors such as treatment participation, appointment attendance, or substance use reduction. Contingency management has been shown to improve treatment engagement and outcomes across a variety of settings. Successful implementation of contingency management depends on organizational readiness, leadership support, and staff willingness to adopt new approaches. So we were assessing the readiness for local providers within Clark County to learn and adopt. And this is what we found. So the sample size is small because we were looking at providers in Clark County. We sent this to all providers that we could get a hold of, clinical director and above. So respondents were 22, approximately 64% in outpatient settings, and 64% serve 60 plus clients per month. Next slide. As I said, the majority of respondents, 64%, work for outpatient treatment providers, making them the largest and most represented group. Residential treatment programs came in at 18%, followed by several categories at 14% each. Community mental health providers, MOUD, or MAT-specific organizations, prevention agencies, and recovery community organizations. And then a smaller number, 5%, were from certified community behavioral health clinics, also known as CCBHCs. Because participants could select more than one category, these percentages add up to more than 100%, and this reflects the reality that many agencies in our communities serve multiple functions. All right, next slide. Turning to who specifically responded, 32% of respondents were in administrator or leadership roles, which is significant because this means that people who can make the decision to adopt contingency management were well represented in the survey. Another 23% were clinical staff or coordinators, 23% fell into other roles, 18% were program managers or supervisors, and 5% were peer support specialists. And one more number worth noting is that 64% of respondents serve more than 60 clients per month. The first finding is the knowledge gap that exists around contingency management. When we asked providers how familiar they were with contingency management, 43% say they were somewhat familiar. So most have heard of it, but familiarity and confidence were very different things. When we asked whether they could explain contingency management to a client or a colleague, 56% said they were not confident at all. Only 25% felt very confident. So this tells us that the basic awareness training needs do come first. Providers know the term, but they need this deeper understanding in order to practice and advocate for adoption within their own organizations. Next slide. So we also wanted to know how supportive and ready to adopt contingency management providers were. Approximately 70% of respondents said their organizations are very supportive of behavioral health incentives like CM. 57% said they were very interested in participating in training, and 58% already have formal systems in place that could be adapted for contingency management, things like tracking tools or appointment systems. The two biggest obstacles cited were by 55% of respondents are lack of funding for incentives and limited staff time. And so when we asked providers what kind of training would be most useful, to content areas tied at the top, an introductory overview and practical implementation, along with workforce integration, both selected by 77% of respondents. So this confirms what we expected. Providers need to start at the beginning, and then they want training that translates directly into their day-to-day work. So 40% prefer self-paced online modules and 35% prefer live virtual training. And then for scheduling, Tuesdays and Wednesdays seem to work best. Next slide. So to wrap up the data points, there are 3 clear priorities for a contingency management training program. First, start with this introductory overview so that we can lay a strong foundation, make it accessible. The majority of providers do want online delivery on Tuesday or Wednesday afternoon. And then third, address real world constraints head on. So the funding and then staff time were the 2 most notable barriers. And then what we were happy to see is that the provider community seems very supportive of learning about and then integrating within their organizations. And then on the next slide, we have 3 overview training series that are going to be presented to Clark County providers. And we'll be going over the scope of stimulant use in Southern Nevada, effects of stimulants on brain and behavior, psychological and behavioral principles of contingency management, what are the essentials for implementing and beginning a program, and then strategies for financing and implementing. And so providers can register for 1 of 3 sessions. Questions or additional conversation? And Michelle, feel free to jump in.
Thank you so much for that great
Sorry,
information,
Steve.
Michelle. Do we have anyone today, any of our subcommittee members with any questions or comments. I see Giuseppe.
Yeah, just quick question, Giuseppe Mandel for the record. And thank you for the great presentation. And I mean, we all come from different varies and backgrounds in this group and around. And so we live in a world of acronyms and definitions, which, you know, CM could mean a million things. I kept thinking case management every time I seen CM. So can you just give us just like a 10-second overview of contingency management and what it is for anybody who may not know?
So contingency management is a evidence-based approach that uses positive reinforcement to encourage desired behavior. So positive reinforcement can be a number of different things that an organization wants to use to ensure that people are testing clean with UAs, attending group, attending appointments, and being present in their treatment. And so we'll go over during the presentation and the training what types of positive reinforcement an organization can consider.
Thank you for
Great.
that. I appreciate it.
I see Assemblymember Golding with her hand raised.
Hi, thank you. Thank you for the presentation. A couple questions. So I'm wondering if you can talk about the costs associated with contingency management. So are the costs, the training costs, program costs, incentive costs? It wasn't clear to me which of those categories might be included in costs. If we were to make a recommendation based on this presentation, can you flesh out what kind of a cost would be associated with it that we would be hoping to cover?
So costs associated with implementing contingency management within an organization would be the cost for reimbursement of incentives. And so it's a certain amount over the duration of treatment. And so each state looks at that a little bit differently. There is no current reimbursement infrastructure that exists in the state of Nevada for reimbursement for utilizing contingency management as an approach to engagement and treatment. And so, like if we look at our neighbors in California, it's roughly I believe $499 that they can put towards the incentives, but these incentives are small. And so it's really dependent on how the organization wants to use them and then for how long um, the duration would be.
So can you concretely give us an example? So you show up to your appointment, you get a clean drug test, you get $50. Is that what we're talking about? Or
you show up to an appointment, you get a clean UA, and you get $15 voucher towards food. You get $15 towards gas, like something that's perceived of value to the individual that's that's attending the treatment, and that can look differently.
Okay, so those are they're pretty modest incentive levels then, $15 for something.
Mm-hmm.
Gotcha. So there are no training costs or program costs other than that incentive, those incentives when we're talking about this program.
Correct.
Thank you for that clarification.
Mm-hmm.
This is Dr. Partita Corona. I'm sorry, I can't figure out how to raise my hand on this thing. Just so you know, we're already using some level of contingency management in the outreach that we're doing. And to give you an idea, we're working with predominantly unhoused patients, and it has served us well. Our contingency management is $10 cards, and what we use it for is basically to further engagement, like let's say encourage them not just to do urine drug screens, but also lab work to confirm a diagnosis of, say, hepatitis C, so that we can advance the care there as well. And in the long haul, 10 or $15, yes, it adds up, but it pays off on the long haul, because that's a patient that you're actually going to advance care with for their hepatitis C, which will keep them from fulminant liver failure, which is a lot more expensive to treat once they end up in the hospital. So it's kind of a preventative measure to avoid much higher costs downstream. I had a couple of questions though. As far as the folks that were involved in the survey, how many of them were actually treating stimulant use disorder? And of the subset of types of workers, like say counselors or providers or peer recovery navigators, which of those subsets were more resistant or less informed regarding contingency management?
Michelle, do you happen to know?
I would assume, given the population we sent the needs assessment survey to, that most of those organizations are seeing some methamphetamine use. I don't think we asked specifically which subgroup was seeing that kind of resistance to implementing the CM into their programs. I think overall we did see a high level of agreement that this is a protocol that they would like to implement into their facilities, given the incentive, us being able to meet incentives for the participants once they implement.
Okay, the reason I ask is because what I've found doing contingency management out in the field, it's vitally important that everybody in the outreach understands the value of it. And so I was thinking, by understanding which subset was most resistant, we could target the education towards them.
And that makes a lot of sense, yeah.
Great. I see Stephanie Cook with her hand raised.
Yeah, thank you for this presentation. I oversee the substance use programming for the state of Nevada within Division of Public and Behavioral Health. And so various grants and state dollars for this work. We are currently finalizing our contingency management model, our funding model, on how we can use some of our grant dollars to support some of this work. Obviously, more strings attached and boundaries that we have to put in place when utilizing federal dollars, such as no cash incentives, and certain gift card restrictions because they're federal dollars. So we have done a pilot with some of our agencies already in contingency management, but we are finalizing our funding model, so we'll be able to release funding specifically for this purpose. And then again, with all the restrictions that we have with our grants and how and what we can pay for. On our mind right now that we have built into our policy is gift cards, gas cards, bus passes, hygiene kits, vouchers for items that support well-being and recovery, and then non-monetary items. And then unallowables for us, because it's grant money, is cash incentives or gift cards, prepaid debit cards. So we are working at this at the state level to really help build out the funding mechanism that can help support some of this work. And like Michelle said, it's a lot of the actual incentive that needs help funding. A lot of the other supports are already in place at these treatment agencies as far as the team that's needed to help organize this and implement it. So we are excited to also push out this model to our community and allow for some funding streams to attach here.
Right. Do we have any other questions or comments for Michelle Berry or Michelle Solomon? Okay. Thank you again, Michelle. And Michelle, we really appreciate you being here and sharing this great information. Thank you again.
Thank you so much.
That will include item number 4. We will move on to item number 5. We have a lot of ground to cover under this specific agenda item today in a very positive way. Before I turn over to Kim, I just want to stress, I know we have lots of new members on our subcommittee and has brought lots of great enthusiasm to our subcommittee, which we all appreciate. I just wanted to stress we have a very tight timeline that Kim will go over in just a moment, and we can certainly talk through. But yeah, unfortunately, we have a very tight timeline to be able to finalize our recommendations to get before the full surge for consideration. So just knowing that, we do have a lot to cover today. So I'm going to turn it over to Kim to just briefly walk us through what we're anticipating.
Thank you, Chair Shell. So what we have up on the screen, we did present in February, and so we just have 3 slides here where I just want to remind folks of the timelines that we're working on. So this first slide represents the meetings that we currently have scheduled for the subcommittee. So we do ask that folks confirm that they have these on their calendars, especially if you were not on the February meeting, just to confirm that you have them and that you know that you'll be attending. The first 4 meetings under the 25-26 report cycle, those represent the meetings that we have to refine and rank any subcommittee recommendations that then go to the full surge for inclusion in this next iteration of the annual report. So one thing that I wanted to add to what Chair Shell was saying is that if a recommendation, for whatever reason, is not able to be progressed and ready for inclusion in this annual report, which I will show you on the next slide, I will actually go to the full surge timeline to start with. So if those are not ready and able to be included in the report that is published in August but approved in July, that doesn't mean that those recommendations are off the table. It just means that they'll continue to be a topic of conversation at this subcommittee for as long as the subcommittee elects to continue discussing them. So just to make sure that was clear, if they don't make it in this time, they don't come off the slate, they absolutely can remain if that's what the subcommittee elects to do. So what we have now today is our March meeting where discussing preliminary recommendations and doing subject matter expert presentations, such as the great presentation we just got from CASAT. And then in May, this group will come back together to finalize and rank their preliminary recommendations for presentation at the June surge meeting. What will happen in between those 2 meetings is an April surge meeting that will occur where those preliminary recommendations from each subcommittee will be shared with the full surge to make sure that everyone knows the work that's being done, potentially look for any feedback on those from the full surge and or any alignment between recommendations that could be leveraged. After that, as I noted, May, that feedback will come back to this group in May to support finalizing and ranking those recommendations. So that's where the timeline really does get tight. After that, the surge will meet in June to review your final slate of ranked recommendations. And we have a June subcommittee meeting held if it's necessary to incorporate any of that final feedback from the surge. So this really is an iterative process monthly over the next few months to prepare the full surge to review the final slate and approve those for inclusion in the annual report and the annual report itself in July. So I know that that is quite a bit of back and forth, but that is hopefully the clearest way we can describe the timeline that we have moving forward. As a note, folks have seen this slide before. If subcommittee members are interested in submitting recommendations, we do ask that you do that via the survey link that we provide directly to you. If you're not able to complete the survey in its entirety at one time, please feel free to just put an asterisk or something else in the open-ended question so that you can progress the survey. You can also reach out to me directly for any help completing the survey. And I will turn it back over to you, Chair Shell.
Okay, thank you so much, Kim. Yes, Kim mentioned we've got several recommendations today that we're going to walk through, some of which we've been fleshing out really for about the last year or so. And then we have some excellent recommendations that have now come forward from Dr. Perdita Corona. So thankful to you, Dr. Perdita Corona, for all of your work you put into bringing forward some great recommendations. So currently, we do have 11 recommendations that have been proposed by our subcommittee members. And I will say, in my years on the surge, I've never seen this volume of recommendations from a subcommittee, or our subcommittee for that matter. So very excited that we have some great ideas coming forward. And we'll talk through some of these, as Kim said, we may certainly continue to flesh out beyond this month and may not actually make it into this current report cycle, but we'll do our very best based on our discussion today. So we wanted to start with the first recommendation that we've been fleshing out for quite a while now. Many of you saw this in our last meeting. This was submitted by Chelsea Cheatham last year and is now being co-sponsored by our subcommittee member Stephanie Cook. But I'll just reread this. It is a retrospective assessment and a prospective study would be conducted to assess the outcomes of patients following discharge from detoxification and examine mortality and overdose. This study should ideally cover a 5-year period and include both people with private insurance and those who utilize Medicaid. And I will note the information you're seeing in italics there was recommended in our meeting last month to be included in this recommendation. So that is an addition to this recommendation. So I wanted to now open it up to our subcommittee members if there are any other further edits to this recommendation. Also to seek your guidance on whether or not we want to specifically call out potential partners in the recommendation who would actually complete the study or execute the study. So just something to keep in mind there. I think we briefly touched on that last month, but if there are any further edits that anyone may want to propose to this particular recommendation, we'll open that up now.
And Chair Shelley, I apologize for the interruption. I just wanted to note for the record that I believe one of our subcommittee members may have departed, which is Assemblymember Edgeworth. And I just wanted to confirm if she is still on the call. If not, we do still have quorum, but we do want to note when members may be exiting to ensure we do continue to have quorum.
Thank you for that, Kim.
Okay, so I did not hear her indicate she is on, so
okay.
I will interrupt again with pre-apologies if I do see her come back on.
Oh, no worries, Kim. Thank you. And thankfully, we still have quorum, so that's good. Okay, if there are no other further comments yes, Dr. Perdita Corona.
Okay, so as far as this recommendation, I think the School of Public Policy, School of Public Health, and the fellowship at Southern Hills could probably coordinate to prepare that study. That would be my recommendation.
And Dr. Perdita Corona, are you recommending that we incorporate those specific agency names into the recommendation, or would we include that as part of our context in our justification document for the recommendation?
I think we should do some outreach to those institutions and see if they have the bandwidth to coordinate a study.
Okay. But aside from that, Dr. Perdita Corona, are you okay with us moving forward on this recommendation and presenting it to the SURG? Okay, thank you. Awesome, thank you.
This is Stephanie.
Yes, Stephanie.
I just think there's too much going on in this recommendation that it's so broad. So if we look at outcomes of patients following discharge from detox, it should probably say withdrawal management, and examine mortality and overdose. I mean, I think that's looking at suitors data. It's looking at, and then is it fatal overdoses? Obviously mortality is fatal, but so I think there's a lot going on here, and I think we just need to pick exactly what we're looking for. Are we looking at only withdrawal management facilities? And if so, you might not get all insurance. So, and then depending on who's doing it, you might not get all insurances. So was the intention to look at only withdrawal management facilities, people leaving detox?
That's my understanding from Chelsea, yes.
Okay.
Well,
so just coming from a state perspective, I would only, because we certify those agencies, I would only be looking at our certified agencies that are certified to do withdrawal management. That might not be the intent of what this was meant to look at. And then are we looking at mortality only related to overdose or mortality in general and then trying to tie it back to overdose would just be my question. Like,
Well,
I just think it's too broad. It's not specific enough to really know what exactly we're trying to get out of it.
it's my understanding that we're trying to look at morbidity and mortality as associated with overdose post detox, but I don't think it was just detox. I think it was including rehab, and I think it was a comparison of basically continuing MAT versus not post detox and rehab, because I
Just
think
having
that's
that
really
for the record.
the crux of the
Yeah,
question.
I mean, Dr. Corona is right. I believe, and I could be wrong, the goal of the study would be to utilize what is working best, whether it be MAT, whether it be just detox and PHP IOP, whether it be detox residential and PHP IOP. And the reason why looking at the differences of a private insurance versus Medicaid is Medicaid generally only pays for detox, and then a PHP IOP program where a private insurance pays for detox, residential, PHP, and then IOP. Um, Mixing both MAT and non-MAT, depending on what the patient wants to do, and to see what outcomes are better so that we see where we're failing in the state, with attempts to hopefully the state would step up a little bit and start helping the Medicaid population as well, so that the mortality rate lowers, as well as what is the mortality rate of commercially insured versus Medicaid clients, which most of the mortality is going to be in your commercially insured population, not necessarily your Medicaid population. If that helps, Stephanie.
Yeah, I just think that's a lot. So, I'm just trying to think of
Giuseppe
how it could.
Mandel, for the record, keep in mind, Stephanie, we are at the bottom and behind the curve in these studies.
Yeah, it's Stephanie Cook. So I think and I'm doing some of this work right now, but I'm very specific looking at like substance use treatment facilities, right? Because that's my sphere of influence. Like we certify those agencies. That's where I can get that data and assess it. But if we're just looking in general, all of these entities across the state, I just think we need to focus and so this is reading like it's a withdrawal management facility, and then just examining the death that occurs after discharge for a withdrawal management entity, for all insurance types. So I'm just trying to think of how to incorporate what we're trying to get out of it without, and that's been Nevada's problem is we got too many systems going on. It's hard to link everything together and really do a lot of this work. So if we take chunks out of very specific facilities that we're looking for this information from, it'd be more manageable, I think, if we're looking at a recommendation.
Well, I agree with you, Stephanie. I think you're right. Limiting this as much as we can. I do agree that this is broad. I know in the state of Connecticut, who was brought in, as a subject matter expert on this, and they've done lots of great studies through the years. They also have a much more robust, behavioral health system of care across the state too, and are much more further advanced than we are. So I agree with you that I think if there's a way to limit this, we probably need to do that.
Well, we could limit
But
it to credentialed institutions for starters. I think
yes.
that would be the obvious choice. Um, but I think at the crux, there's two questions that we're trying to answer, and that is MAT versus non-MAT post detox and rehab treatment. That's one. And then Giuseppe, correct me if I'm wrong, but your question is more whether or not providing, I guess, covering detox by Medicaid, which it currently doesn't cover for some patients. Is that right?
Giuseppe Mandel, for the record. No. It is the limited amount of time that they'll give for detox and then residential treatment versus just detox and then right into PHP, which is usually what Medicaid wants to do.
Okay, so your
And
question
we're unique in that state.
your question is, do patients fare better if they go detox, rehab, and then PHP versus detox straight into PHP?
Correct.
Okay, so those are the two questions then that we're trying to answer.
So I will just note, I have an editable version of the slide up. So if there are any changes you'd like me to make live, I'm happy to do that. I might just need a little more direction from the group.
Stephanie, is your first thought to add to make sure we note that this would focus on certified withdrawal management facilities?
That would be my recommendation because
Okay.
that's where the state has the sphere of influence is who we certify. So I would change detoxification to certified withdrawal management entities or facilities. And maybe examine causes of overdose. And I think that would give us non-fatal and fatal overdoses. Like, so, what is happening and maybe a timeline within, I think we're looking at within 6 months on a lot of our reports. So like within 6 months of discharge from a certified withdrawal management facility, where are people going? And are they seeking care in those first 6 months?
Well,
So
that's the thing though, is that that's the problem with these studies, is that they're always so short term. We need to look at a longer horizon.
okay, and that's where the
Because
5-year period was coming in.
yeah,
Okay,
because
so
we really need to look at long-term recovery, not just consider someone sober for 6 months a success.
yeah,
Because
so okay,
that's why we keep on having relapse and repeat admissions and so forth, is that we're not looking at the long-term horizon.
yeah, that's perfect. Okay, so within 5 years of discharge, and then examine causes of overdose. I don't know that you should call out the insurances because depending on who is going to do this work, their scope might be limited on the data sets they have or whatever. So maybe we just say, I don't know, whether we say like for all Nevadans or just leave it at that, and the expectation is to assess that data.
But just have been out for the record. The reason why we're trying to assess the difference is because commercial insurance will pay for residential treatment. Medicaid limits that, and that's why we keep seeing the what we call a spin dry, in and out, in and out, in and out of facility, and they may not be dying, but they're in and out of the facility nonstop, and there's no progression over, the after 6 months or 2 years or 5 years, they're just in and out, and that's absorbing a lot of Medicaid state dollars when we could put the money up front, pay for full residential treatment, and you probably save a lot of money on the back end. And I
So
know
we're
that's a 5-year study, but
So one way we could do it is speak to the pattern of step down, which is really what's differentiating there. Does that make sense? That and the use of MAT and the length of MAT use.
And is that something you are seeking inclusion in the recommendation itself for clarity? And if so, could you help me identify how to add it? And then Stephanie, I do have a follow-up with you on the causes of overdose. I just don't want to forget to ask you. But Dr. Partita Corona, were you suggesting changes to the recommendation that I could add in currently?
Yeah, so under causes of overdose, specifically use and duration of use of MAT and pattern of step down.
And this is Stephanie. Just real quick, when you say MAT, do you mean MOUD, just the medication?
Yes.
Okay.
So would you recommend changing it, Stephanie? Okay.
Yeah, I would recommend changing it to MOUD. Yeah.
Can I ask a question? Would people be comfortable with moving the specifically pattern of step down and use of MOUD elsewhere? Right now, I will just say it reads as if it is a specific cause of overdose because of where it's currently in the recommendation, because it says examine causes of overdose, specifically pattern of step down and use of MOUD, which I don't believe is what you intended by causes of overdose, right, Stephanie?
Right.
So is it that you want the study, Dr. Partita Corona, to include exploration of the patterns of step down and use of MOUD by these patients?
Yes.
Okay. Including, I'm going to put analysis, but that might not be the right word. Trends, maybe? And then, Stephanie, if I could ask on examine causes of overdose, some folks may read that as what the overdose resulted from, right? Was it an intentional overdose? Was it an accidental overdose? Things like that. Is that what you intended? Because I also heard you say mortality and morbidity, and I just want to make sure I have this as clear as possible.
I think I read this as we're trying to figure out why people are overdosing within 5 years of being discharged from a withdrawal management facility when all these things should have occurred during that time, right?
Mm-hmm.
So I think my examine causes of overdose is like what missed opportunities were there for those clients within these 5 years? Were there any missed opportunities during that time?
It might be.
Now, because it's a 5-year study, I'm assuming we're following people that like the study would follow people, to link all those things together. But mortality data is not going to it's not going to follow people, right? It's gonna so I think leaving just overdose in there leaves opportunity for both fatal and non-fatal to figure out what is happening in our system of care that's not working.
Agreed.
And just having that down for the record too, I think the goal was too, is you could take patients over the last 5 years who are sustained recovery already and go backtrack of their journey. So we don't
And
have to wait it out 5 years. You can also take patients who have already sustained 5 years of recovery and backtrack what they did in the last 5 years.
yeah, for sure. Yeah. And I think that brings up another point is if we have and or in here, do we want that? Do we want both? Or or are we
We want both.
okay. Okay.
Stephanie, I don't know that I quite got it right, but I did just leverage some language that was from the original justification for the recommendation. So
Yeah, I think that looks good. Yeah.
if that feels aligned. Please also let me know if things are not in alignment with what you're saying.
Just real quick, because I keep hearing the withdrawal management, certified withdrawal management facility. What exactly does that cover? I mean, does that include? Are you referring to MAT treatment clinics and detox and residential treatment facilities, or is that just MAT treatment clinics?
Stephanie Cook for the record. The updated language for detoxification is withdrawal management. So it's your traditional detox facilities that that folks usually enter first if they're in need of withdrawal management services. So it's just updated language that is less stigmatizing for those services, but the same types of services, like entities that provide that care.
Oh, thank you, Stephanie. I appreciate the clarification.
Now, are we also still proposing to include the statement about insurance, or did we want to reword that a different way?
I think now because we put in the bit about the patterns of step down, we could probably remove the Medicaid that way.
Just having that out for the record, the only reason I'd like to have it in there is it helps us, don't take offense to this, Stephanie, put boots on the state and payers to show the difference of, commercially insured paid treatment and where they pay at versus the archaic pay structure of the state of Nevada, which is, I don't think it's been increased since 1980. And I think that's part of the goal too, to kind of get the state to get up with the times and pay for treatment in the, times where cost continues to go up, and we don't want to cut treatment if the state doesn't want to pay, because in the long term, it costs the state more money by continuing to pay for those patients. Does that make sense?
Yeah, Stephanie Cook, for the record, I think that's cool, but I think it's a different recommendation because this is saying, hey, like, hey, we want someone to study all this stuff. And then I think this is almost the outcome we're hoping to get out of it, right? Like we're trying to then take all this information and do something with it that we can help boost the support we need in the state to support all these things. So I think it's cool and I think it's good. I just don't think it belongs in this recommendation because it's kind of outlining.
And agreed. The only thing is, how do you compare the two then for later on in the next recommendation?
And maybe what we do is assess the outcomes of all patients. And then that allows for the assessment to delineate between different types of patients and whether that's insurance or any other kind of contributing factors to the diversity of the patients.
Brilliant and agreed, Stephanie. Thank you.
Any other possible edits to the wording of this recommendation?
Just to clarify, did I do that correctly? It was decided to remove the reference to the two Medicaid or to the two insurances. Thank you.
I think this looks great and it's much more specific. So I think this has been a great discussion. Okay, if we don't have any other further discussion about this recommendation, we'll move on to the second recommendation that we've been fleshing out for the last year or so. Just to read this one again quickly, to recommend to the Nevada Department of Human Services that they financially support the implementation of embedded hospital emergency room-based peer recovery support teams. This could be via dedicated general funds made available to hospitals or by encouraging applications for the use of Fund for Resilient Nevada monies. So you'll see that in our last meeting, we did incorporate the word embedded. I know, Dr. Perdita Corona, you had a couple of other items to add to this recommendation we wanted to talk through today.
Yeah. There was a recommendation that I basically made about making the access to the state opioid funds to hospitals contingent on them adopting certain things, namely a delineation of privileges for addiction specialists and opening up a pathway not just for them, but for mid-levels that would be supervised by the addiction specialists and peer recovery navigators that I think should be part of that same addiction consult team. The whole goal there is basically to put the onus on hospitals to make that happen rather than be stagnant in opening the door for addiction medicine in the hospital setting. Because without it, I don't see addiction as a specialty making it into the hospital, simply because the hospital administration won't give it priority to set up those delineations.
Dr. Bartiga Corona, I think that's excellent. I wanted just to ask for your thoughts on how the rural hospitals might approach this that don't have, the means to be able to have addiction specialists, but yet they've got peer recovery support specialists in their communities.
Oh, okay, so several things there. One, with telemedicine, there exists the opportunity for them actually to have addiction specialists weigh in on cases in the rural communities. What's more, this isn't a mandate for them to actually have an addiction specialty consult service. It's a mandate for them to set up the mechanisms by which an addiction specialist can apply for privileges, or a mid-level provider can apply for privileges, or peer recovery navigators can apply for access. So that won't really cost the hospitals much at all. In fact, if anything, it will probably reduce bounce backs and make them better off financially if they do. But again, it has to be something that they're led to, because of their own volition, they probably won't get around to it.
Yeah, that makes sense to me, Dr. Bartiga Corona. I appreciate you elaborating on that. Thank you. I see Stephanie Cook with her hand raised.
Okay, so my recommendation on this would be, I think it's always hard to call out a funding source. I think general funds is cool to keep in there. But as far as like encouraging applications for use of FRN, I would almost say encouraging applications through the department, because I have funding that can help in this space, and we're doing some work in this space right now anyways. And then, the FRN has a plan they're working from, and they may not always just be able to just start funding something. So I think just calling out through the department allows for more opportunity to focus on some of this work that's not tied to just one funding source.
Yeah, much better, Stephanie. Thank you.
Okay.
So, Kim, I think based on what Dr. Perdita Corona is saying, I think what he's saying would be added to the end of the first sentence.
I did want to ask.
Maybe.
Oh, I'm
Oh,
so
go
sorry,
ahead.
Steve. I wanted
No,
to
go
ask a
ahead.
follow-up because, and I apologize that not everyone has this information, but there is Dr. Partita Corona, this is very similar to one of the other recommendations you submitted last night via the Survey Monkey. And I'm just wondering if the intent is that these would merge. And if I could bring up the other one, I can post it on the screen at the same time so the group could review them together. Okay, let me do
That'd
that.
be great, Kim.
So, and just as a note, while I do that, I wanted to note to the group and the attendees on the meeting, we intend that a updated recommendation survey, or sorry, recommendation summary that was attached to the meeting materials and that was also distributed to subcommittee members will be updated with a total of, I believe, 11 recommendations. So we did receive quite a few yesterday, and that will be distributed following. So I apologize that folks don't have that in front of them. So let me change some of this sizing to just get a little more consistent. So I will note the one on the bottom in full italics is the one that Dr. Partita Corona, you had submitted yesterday. And so it may be that these can be aligned.
Yeah, I like this, Kim. I mean, this is exactly what he was just saying. And I like incorporating it into this recommendation. That makes sense to me if it does to the rest of the group. So DHS would essentially financially support those hospitals that have established the delineation of privileges and implemented an embedded ER-based peer recovery support team. So however you can wordsmith that, Kim.
Yeah, so is the intent recommend to DHS that they financially support the implementation of embedded hospital emergency room-based peer recovery support teams and
Or
is it
should it
that
be
is
for
it that
those
what we're
hospitals that have established delineation of privileges?
well, when I look at this bottom one, this does seem, and I just want to make sure I'm doing it correctly, is that this seems that the end goal of this is that there's a cohesive addiction consult service within the hospital. So is that the actual intent, and should that be the first part of the recommendation? That they financially support the establishment of cohesive addiction consult services within hospitals and ERs through, and then we would describe the following steps. Is that the intent?
I see where you're going with this, Kim. Yeah, I like that much better. And I think that is Dr. Pardita Corona's intent here, if he agrees.
Yes,
Yeah.
because ultimately, peer support is great, but having addiction specialists on staff is infinitely better as far as backup for the physicians in the hospitals, as well as warm handoffs to outpatient treatment. Not to mention it creates job opportunities for the fellows that were graduating from Southern Hills. So it builds the bench.
Yeah, I like this much better. Any other thoughts from our group?
I don't know that I quite have it right, but is
Let's
this what
see.
folks were intending?
If everyone could take a moment and read through this.
I think this is Stephanie. I feel like it reads like the department has to fund these services in a hospital.
Just Stephanie Mandel for the record. I think the goal was to incentivize the hospitals
Yes.
with funding.
The way I see it, the key really would be to incentivize more the adoption of those delineation of privileges for providers and mid levels, and financially support the adoption of peer recovery navigators in the hospitals embedded in the ERs. So the peer recovery navigators would basically be employed by the hospitals, but work with the consult team. Does that make sense?
Yeah.
Kind of like ER nurses work with the ER group that's contracted for a particular hospital. That way, the only cost that the hospitals are bearing is the cost of implementing delineation of privileges and the cost of peer recovery navigators, which are the bare bones boots on the ground. And the cost for the mid-level and the addiction specialist would be borne by any of those that are applying for privileges. That would be the consult group itself. It's on them to bill and on them to generate their own revenue. But it builds the bare bones infrastructure to accept them into the milieu of the ER.
Kim, I'm thinking maybe we also remove encouraging application since we removed general funds and FRN. Since we already say to incentivize the implementation.
I just want to make sure I'm tracking what Stephanie was saying as well around, Stephanie, if this represents what you think is possible and what would be manageable. And Dr. Partita Corona, I'm not sure if I don't believe I got all of your nuance in here about who would be funding what pieces. And I'm not sure if that's something that you want clearly stated in the recommendation.
Yeah, I do, because that's very important for actual adoption, because I don't think anyone really wants to fund the adoption of specialists into the hospitals. I don't think the funds are there, quite frankly. But the funds are there for hiring peer recovery navigators. And so the peer recovery navigators would be contracted by the hospitals and work with these addiction consult services.
Okay, can you clarify for me who would be funding which piece of that, of the team, if it's a cohesive addiction consult service represented by the addiction medicine specialists and the mid-level providers and the peer recovery navigators? If you can lay out that funding, I could take a first pass at noting it.
Okay, so the best comparison would be an ER as it stands now. In the ER group is contracted, right? But they do their own billing for the services that they render. So they're basically just like a hospitalist group that works in a hospital. They're getting paid by Medicare, Medicaid, and private insurance and so forth. But the hospital hires the ER nursing staff. So they are employees of the hospital, but they do work in tandem and under the direction of the ER group. It would be the same setup where the peer recovery navigators are basically kind of like the ER nurses. They're hired by the hospital.
And how is DHS incentivizing it? What is DHS's contribution? Because that's how the recommendation begins.
DSH's contribution, you're talking about the funds that the hospitals are receiving?
I'm not sure. Just right now, the way the recommendation is worded and how it began was recommend to DHS that they. So right now, the recommendation is specific to what the group would be advising or asking DHS to consider doing. And so if that's incorrect, then I would need to update from the beginning of the recommendation.
Okay. So basically, my recommendation is that the hospitals receive funds for from basically the opioid fund if they do the following: hire peer recovery navigators, which that cost is covered by the fund, and set up these delineation of privileges for addiction specialists and for mid-levels that would work underneath the addiction specialists. Does that make sense?
Possibly. Let me write it out. I just want to make sure I have it. I think this may also be from a few, combining a few recommendations. So I just want to make sure I have it correct for you all. So hospitals will receive the opioid settlement funds to hire peer recovery specialists. That's what those actual funds are used for, if they meet certain criteria.
Yes, and that criteria is the adoption of delineation of privileges for addiction specialists to work in the hospital, along with mid-levels, along with a path for peer recovery navigators to get, I guess, allowed in the hospital.
Okay. Is that it?
Yeah,
Did
I
I
know.
get closer? I
Yeah,
appreciate your
I like
patience.
this. That was my original intent with the recommendation is that DHS would incentivize the hiring of the peers. And now I like Dr. Pardita Corona's addition of if the hospital does the following, then they're eligible to receive those funds. I like this.
This is Stephanie. I would just go back to removing opioid settlement funds because that's a very specific funding pot that you may not be able to tap into right now, depending on all the stuff that they've got going on. So yeah, I
Yeah.
would say department funds because it could be more than just opioid settlement. I mean, they have a whole plan that they have to do, and yes, there's opportunity for new programs, but it's not just an ongoing slush fund, really. So, but I've got funding too that can help with this work. So I think we should just leave it as department funding to hire.
Okay, that's great.
Yeah.
The only other thing that I'll throw out there, and it doesn't have to be on this part, but Nevada, Sam Ori has written up delineation of privileges that we can share with whatever hospital bites. So they don't even have to do that work. We've already got that written out.
Okay, this has been great discussion. I like where this has gone. So, do we have any other thoughts or edits for this particular recommendation?
I think you just need to get the word fund in there after department.
Oh, thank you, Assemblymember Golding. Okay. All right. So, hearing nothing else on this one, we will move on to the third recommendation. This has not been fleshed out for the last year, but it has been fleshed out for a bit of time. This is on contingency management. All of our subcommittee members know that we just heard from our leaders at CASAT on this particular topic. So, what is everyone's thoughts on this particular recommendation as it is currently written?
Stephanie Cook for the record. I think I would just be specific, increasing state funding. If that's the intent, are we looking at state managed funding or just in general, are we looking at increasing funding? It's been my experience that a lot of these recommendations are aimed at the state. So we just got to be specific that it's state funding we're looking at increasing.
I would also recommend that we make a recommendation in there that the funds be doled out in $15 increments. And I say that because if people see that it's only $15 that we're doling out, they might be a lot less hesitant about saying yes. Plus, being the guy that has to go get the cards, $10 doesn't work because the vast majority of the gift cards out there are $15 to $100. So you have to put in at least 15.
Giuseppe Mandel for the record, and Stephanie can probably confirm this. There are state laws in place where it's going to limit the amount that you can give out anyways, the body broker laws and the patient broker laws. So there'll be laws limited. I'm sure Stephanie can attest to that.
Yeah, Stephanie Coke for the record. The funds that we oversee has the stipulations attached to the types of incentives that we can fund with federal dollars. So right now, our state opioid response grant funds some of this work. We have to adhere to the federal guidance as it relates to contingency management, which right now they've increased actually this year. The cap right now is $750 per person that they can receive in contingency management. So we do have to adhere to the rules of our grants. And so I think the problem is if you put a dollar amount in here, it's too restricting because I probably couldn't, if I were to fund this from our division, I probably couldn't do a lot of those based on very strict recommendations. So I think that Dr. Pertina Corona kind of just goes along with who's funding it, right? If it's general fund, we can do whatever we want. If it's grant funds, then there are restrictions.
Fair enough, but when you write the grants, just keep in mind the $15 cards rather than 10, because 10's a pain in the butt to find.
Is the revision currently on the screen, does that align with what folks were indicating? And I also wanted to test if the group wanted to retain the bottom part of the recommendation. So it would look like that.
It's Stephanie. I don't know that the last sentence matters in the recommendation. Like it does in the bigger picture, but I think the recommendation is pretty clear and specific.
Yeah, and just let me point out for the record too, that last line is gonna conflict with, I'm not talking about grant funding, I'm talking about actual laws for providers of what you're allowed to give out and what you're allowed to not. So yeah, that probably, I mean, it sounds nice to increase the money, but they're gonna be restricted, the providers, by laws.
So would this be the revised recommendation that folks were looking at?
I believe so.
Okay.
Yep.
Okay, so the next item of business regarding this recommendation is that we need somebody from our group to be the lead on this one, as we have with the other recommendation. So is anyone in our subcommittee willing to serve as the lead since we no longer have Chelsea on our subcommittee?
This is Stephanie. I'm happy to, although I don't know, it seems like a conflict of interest for me to do it.
I mean, Giuseppe Mandel, for the record, I am not as brilliant as Miss Cook. So, I mean, I don't even know what leading means on this.
Yeah, it may not be that you have to really do much else on this one, Giuseppe. We just need a point person on this one in case when we take this to the full surge, if they have any recommendations for us to consider, there may be something we need to run by you, or you lead us in a discussion on, or help us find someone with that information.
Sure, I could
Okay.
volunteer for that.
Okay. Thank you, Giuseppe. Okay, so we will conclude our discussion on recommendation 3 and move on to the 4th recommendation. This was actually brought up in our last meeting by Dr. Pardita Corona. I'll give just a minute for Kim to finish. Sorry, Kim.
No, I just wanted to note, in the last iteration, when Stephanie took on the lead for Chelsea, I believe the subcommittee actually voted on that.
Oh,
There was
yes.
action taken. So just for consistency, I wanted to offer to see if the group wanted to have a motion.
No, thank you for
associated with
keeping us
that.
on track with that, Kim. Yes, would our subcommittee like to entertain, make a recommendation, make a motion to appoint Giuseppe as our lead on that particular recommendation?
Motion.
Thank you, Dr. Pardita Corona. Do we have a second?
Second.
Thank you, Stephanie. Any discussion? All those in favor of appointing Giuseppe, please say aye.
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 Aye. Any opposed? Motion carries unanimously. Thank you, Giuseppe. Okay, so this is our next recommendation that Dr. Pardita Corona brought up in our last meeting that we wanted to talk through and see if there are any possible edits. If you're still comfortable with this one, Dr. Pardita Corona, or anything else you might want to add to this.
I would like to add that it be with any and all
Oh. Did Dr. Partita Corona freeze? I just want to
Oh, I
make sure
think-
that's not just me.
I believe he did freeze.
Okay. I will just note if he becomes unavailable with 4 members, I believe you do still have quorum because it's a
Okay.
membership of 7. So
Thanks, Kim.
you could continue discussions, although I know that all of the subsequent recommendations are all from Dr. Partita Corona.
Yes. Okay, he's back. I think you froze for a few seconds, Dr. Pardita Corona.
Hello. Yeah, I'm sorry. I was getting a call at the same time. So yeah, I wanted to also include language saying that this applies to Medicaid, including any and all MCOs, because they're the biggest culprits of the prior authorizations used to basically block just about anything.
Could you say that one more time? This would apply to all.
Payers.
Medicaid, all payers, including Medicaid MCOs.
This is Stephanie. Just a thought here. Would it be helpful to add a setting into this recommendation? Like, are we looking for in the field with by EMS? Are we looking at ERs? Like, I don't know if putting some kind of setting in here would help be more specific.
We don't want to include a setting because quite frankly, I don't care if this is getting started in the ER versus an outpatient setting versus out in the field with EMT. The point is that we have a very narrow window of opportunity to initiate treatment for substance use disorder, and the other side of that, if we wait for prior authorization, is likely relapse and possible overdose. So the setting doesn't matter.
And then my last recommendation is just changing the medication assisted therapy. I mean, would it make sense just to say eliminate a prior auth needed for starting MOUD? Because that includes all of those words. For initiating MOUD? For
the problem there is that with methadone, I can kind of understand a little hesitance because of all the laws associated with it. And there you are, you're basically opening it up by trying to include methadone. You're opening it up to, well, what if it's not the right setting question? Whereas with buprenorphine, it's pretty clear that can be used pretty much anywhere. And it makes it easier for application rather than trying to include all MOUDs.
yeah, Stephanie Cook for the record makes sense.
So my next question to the group is, do we all feel that this recommendation is ready to be taken to the full surge, or do we think there might need to be some further refinement or even any presenters that we may need to bring in, Dr. Perdita Corona, or is it good in its current state for us to move forward? Any thoughts on that?
Well, I'm good with it as is. If you need presenters, I can think of several. But I think it's pretty good as is.
Yeah, I agree with you, Dr. Perdita Corona. I would feel very comfortable moving it forward as is. How about the rest of our subcommittee members? Is anyone opposed to us moving it forward?
I'm good with it as it is.
Okay, thank you, Assembly Member. Okay, so it sounds like we're good moving this recommendation. So that currently gives us 4 recommendations to take to the full surge. Now, we also have, oh, Kim, before I move on, I wanted to say, do you want to share anything about how our attendees can view the background and the justification for this
Yes.
particular recommendation?
So the background and recommendation for all of the, the background and justification for all of the recommendations has been posted to the SURG website for the first 4 recommendations, including the one we just looked at. However, we did receive 7 additional recommendations that are on subsequent slides. I'm not sure that there's time today to look through those, but the information on those 7 is being incorporated into an updated version of that document. And we will share that with the subcommittee members following the meeting, and then also make sure that it is also posted to the website either as a material for today's meeting or a material for the next subcommittee meeting. So that will be available. And then Chair Shell, I would ask how you would want me to proceed given the timing or the time left in the meeting with the subsequent slides.
Yeah, thank you, Kim. Yeah, I was going to, Dr. Pardita Corona, the 7 additional recommendations you've submitted are excellent, by the way. I wanted to ask you though, are any of, because of the time frame that we're looking at the moment, do any of those 7 in your mind, your opinion, are ready in their current state to be able to move forward, or are they going to require some discussion, possible refinement, and even presenters?
The 24 milligram buprenorphine one, basically eliminating the Medicaid from weighing in on the exact dosing of buprenorphine. I think that one's ready to go, and I think that's probably the most important out of all of those.
Okay.
That are left. And the reason that I would want to eliminate, I don't know if you can bring up, question 3 on the monkey survey that I did for this. The verbiage that I put in there.
It should be up on the screen now.
Yeah. So basically, that's my argument right there.
Yeah, I thought that this would be the recommendation you said was ready to go as is. I felt the same way, Dr. Pardita Corona. I thought the justification is spot on there. Any comments from our other subcommittee members on this? Any questions for Dr. Pardita Corona?
This is Stephanie. I guess I'd just like to see the data of what's currently happening in this space. I mean, I think it's a good recommendation, but like I don't even know what the limitations are from Medicaid or MCOs, and then like how many folks are actually on a higher dose. Like I guess I just haven't seen the data in this space.
So the quick and dirty is this. Currently, because of fentanyl's displacement of heroin, we're seeing that patients, by and large, aren't stable until they get to 24 milligrams these days, at least the majority that are using fentanyl. And as far as the risk associated with it, if you look at the second associated research there, it'll tell you the number needed to treat for. Does everyone know what number needed to treat means? Or no?
You can remind us.
Okay, so number needed to treat is the number of patients that you would have to give that medication at that dosage to get a beneficial effect. For example, well, just so you know, the lower the number, the better the treatment. So the number needed to treat, for example, for aspirin in the use of a heart attack is 7. You would need to give 7 people a dose that are having a heart attack, a dose of aspirin to get 1 beneficial effect from it. So the number needed to treat with a dose of greater than 16 milligrams, which would be 24 milligrams of buprenorphine, is 2. Whereas the number needed to treat when you're talking about lower dosages like 2 milligrams of buprenorphine is 4. So people actually do better at higher doses of buprenorphine as far as maintaining their sobriety. And the only real reason that we make these limitations on buprenorphine is because the vast majority of people making those decisions have absolutely no understanding of how safe this medication is. So there's another stat out there, which is the LD50. In toxicology, LD50 is how much of a medication would have to be given in order for 50% of the people receiving that medication to expire from that medication. Okay. And mind you, this is lab rat data, but the LD50 for, say, Tylenol is, I believe, 2,400 milligrams per kilogram. Okay. The LD50 of buprenorphine is 800 milligrams per kilogram. Now, if you look at those numbers, the average Tylenol dose is 650 milligrams, but the average Suboxone dose is 8 milligrams. So looking at it that way, buprenorphine is actually safer than Tylenol, yet we're treating it like it's radioactive. You know? And a lot of that comes from...
You know me, I love your enthusiasm stuff, but if you're looking for recommendations in the state, you have to be very careful coming at it like that, because there's a lot of conflicting data to that as well. You just have to be very careful. If your goal is to just get prior authorizations for a higher milligram, but throwing in, like, if we throw in terms of sustained recovery and stuff, you're going to get resistance there too, because there's a lot of data that suggests the opposite, especially if you're comparing buprenorphine to Tylenol. You're going to get a lot of resistance, especially from the recovery community.
Well, I'm
So
talking about just
I'm
the
not giving you an
medication
opinion one
by
way or the other.
itself, not because the
No.
vast majority of you do see some patients that overdose while having buprenorphine in their system, but the vast majority of those patients are polysubstance in their overdose. The vast majority of them. So
I'm not arguing with you one way or the other. I'm not taking a side one way or the other. I'm just saying be very careful with the language, because you'll get resistance. You know what I mean? You just speak in black and white fact that we need no prior authorization to be able for Medicaid to pay a higher milligram. But we can't throw in terms like you have a higher probability of sustained recovery and stuff like that, because that could be up for debate, and you'll get resistance on that. That's all I'm trying to say. I'm not picking a side either way. I'm just trying to highlight the blind spot.
Fair enough. I appreciate that, because I do have blind spots.
I see Assembly Member Golding with her hand raised.
Thank you. I feel like I'm uncomfortable with this recommendation because it feels like a recommendation on how to practice medicine versus a recommendation on funding and programmatic recommendations. One of the things that I think is important is that we're essentially playing the role of policymakers here, not physicians. And that feels uncomfortable to me, that it's leaning too far into making medical recommendations, which is not the role of this committee.
I 100% agree with you. However, Medicaid does put that 16 milligram limit. So they are in fact practicing medicine without a license. That's precisely my point, is that that limitation shouldn't exist. And it definitely shouldn't be coming from people that don't have a medical license that's on the line. That's precisely my point.
Okay, so so looking at this, you're saying eliminate the dosage, not. I'd rather see a little bit broader language. I still have some discomfort. I'm still having some discomfort here. Is there some broader language that we can use that gets at the same thing, that gets at the same result? I'm going to back off. I just wanted to explain. This is so you all are more qualified to make this recommendation. I just wanted to express my discomfort But I will.
Well, I think we're on the same page here. I think we're just trying to figure out how to. Perhaps the way to say it would be Medicaid should not dictate dosage limitations, but should leave that to the physician patient interaction.
And should this be limited then if, I mean, bottom line is physicians should be able to do what they do best and are knowledgeable to do, right? Policymakers shouldn't be doing that. And actually funders shouldn't either. Like physicians should be the physician, not this other, not other. But
Yeah.
if so, why limit it to Medicaid then? And maybe I missed something in the conversation earlier, but basically.
Well, the only reason that I made it Medicaid is because Medicaid actually made a policy, and the other insurers went in lockstep with the Medicaid policy. So the other insurers wouldn't have adopted that policy were it not for Medicaid having adopted that policy. That's the only reason.
Okay, so if we make a recommendation and this recommendation got translated into official policy and you left the word Medicaid in there, then other providers, other insurance carriers could say, well, you said that about Medicaid, not everybody else. I mean, so if we're gonna say, hey, let doctors actually practice medicine here, then let's not constrain it to Medicaid. Let's say it and do it.
Okay, beautiful.
Yeah.
Recommend that insurers or payers not impose dosage limitations for buprenorphine when used for medication-assisted treatment.
As a physician, can you think of any time when it is appropriate for any insurance carrier to be setting any kind of dosage limitations at all? Like, that seems inappropriate to me. Why limit it to this medication? Insurers, stay the hell out of it.
The problem is that if we were talking, say, about insulin, right? There's a huge range of dosing that's still appropriate depending on the patient need and the patient response. And we don't see any insurance saying you can't give more than 50 units of insulin for this patient. There's no such, dosage limitation. Now, they may criticize which type of insulin you use because they have a contracted rate for, Tresiba or what have you, but they won't argue the dosage. That is what I'm trying to eliminate, because we are finding that we are needing higher doses depending on what's out there, and we need the playroom, if you will, to adjust to. But in answer to your question, I guess we really haven't figured that out yet, because right now we're stuck at a lower than therapeutic dose that's covered by the insurances.
Okay, so a broader wording might be recommend that insurers not impose dosage for medicated assisted treatment.
Okay.
I mean, it's even broader. It's like, stay the hell out of the process.
Yeah.
So recommend that insurers or payers not impose dosage constraints or recommendations for medicated assisted treatment.
And Assemblymember Golden, would you like to add something, though, just to reinforce what you just said a moment ago about the physician being the one actually prescribing the medication because they're qualified to do that? Do we need to highlight that in such a way?
I'm not sure. Sometimes when you add stuff on like that, that just gives more room to for
For
other people.
misinterpretation?
Yeah, yeah. It's
Okay.
just stay the hell out. I mean, that's one person's perspective who's not a physician.
This is Stephanie, and I think I think we need to say buprenorphine though, because for us, the new updated language for medication assisted treatment is MOUD, and that includes methadone. So I think, and MAT is just an old established word that we're trying to, bring up to the 21st century. So, but I get that providers understand MAT. So I think if the intent is buprenorphine, then we put bup in here because I would look at this and be like, this also includes methadone.
What's interesting though is that currently there's talk of opening up methadone to be prescribed outside of a methadone clinic environment for specialists. So we'll be revisiting this down the road if and when that happens.
Yeah, and that's been going on for years now. I've been trying to do that for many, probably at least 10 years now. So yes, I do agree we have to relook at it. But if the intention is buprenorphine right now, I think we keep it bup.
Fair enough.
I offered 2 on the screen because I think I heard a couple nuances. So I just wanted to ask the group which one better represents where the group is kind of settling.
This
I'm
is
good with the
Stephanie.
top one.
Yeah, I agree.
I agree with the top one. Is anybody opposed to the top one? Okay, and then on that note, is anybody opposed to still moving this one forward to the full surge? Or is everyone on the subcommittee in agreement that as this is currently stated, we're all comfortable with moving this one forward?
This is Stephanie. I agree.
Okay, thank you. Is anyone actually opposed to moving this one forward? Okay, so it sounds like we now have 5 recommendations to be able to move on to the full surge. And we do have 6 other recommendations, and I know we're running very short on time. Dr. Pardita Corona, I know you said this is the one of the remaining 7 recommendations that you thought was, ready to move forward. Are there any of the other 6 that you might want to discuss quickly, or can we then put them on a future agenda to flesh
The
out?
methadone one, I think, might be a quick one.
Would you like me to move forward to that one?
Yes,
The
Kim.
methadone?
Yep.
Okay. Let me just find the number.
4.
Okay, there it is. I did just want to note for the group that we are over time, so I just wanted to note that for the record.
Oh, Kim, I'm sorry. I thought we had 2 hours.
It's a 90-minute, so it
Well, I am
technically
so sorry to our subcommittee members. I was just carrying on as if we had until 1 o'clock. So I sincerely apologize. On that note, I do think we should probably hold on that one, Dr. Pardita Corona, since we're way over time, if you're okay with
Yeah,
that.
I agree.
Okay, thank you. Kim, just tell me quickly, do we need a motion to move these 5 onto the surge for
Not at
consideration?
this,
I don't think
not
so.
at this point. I
Okay.
believe you covered that appropriately, although I did also see our Dag Joseph come off mute. So I'm not sure if he had anything that he wanted to clarify for us. Okay. Thank you.
Okay. Okay, so on that note, let's conclude item number 5 and move on to item number 6 quickly. This is a review and consideration of items for our next meeting. I think we've already talked about reviewing the additional recommendations from Dr. Pardita Corona, but does anyone have any other specific items that they'd like to recommend for consideration at our next meeting in May? Okay, hearing none, we will move on to item number 7, which is public comment. I will turn it back to Kim to walk us through that process.
Thank you. Public comment will be received via this Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment is limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you are dialing in from a telephone, you'll dial 669-900-6833. When prompted, you'll enter the meeting ID 865-8016-1096 and press *6 so the host can prompt you to unmute. We do request that members of the public refrain from commenting outside the designated public comment periods unless specifically called upon by the chair. And then finally, we do ask that folks do not use the chat for any communications, including public comment, as that is not visible to people who are calling in from the phone.
So I think I do see we have a couple wishing to make public comment. I see Jamie Ross with her hand raised. Hello, Jamie.
Hello, thank you. Jamie Ross for the record, CEO with the PACT Coalition. We actually work with peer recovery support specialists in the hospital. There are a couple of really great articles that have come out recently in JAMA that talk about how the connection with MAT, MOUD, and connection to services are more important than the lived experience. And so, again, I realize that you guys can't do anything without putting it on an agenda, but happy to send those 2 JAMA articles to you, Kim, if I can somehow figure out what your email is without you putting it in the chat, but would be interested in potentially suggesting to Chair Shell, as it was his requested item, to potentially put peers/navigators to allow CHWs and other folks who work in that field to also potentially be in hospitals. And I know, Steve, you know very well about the potential issues with peers in hospitals and their background checks. So yes. Thank you so much. Again, I realize you can't talk about this, but I just wanted to potentially bring that up for a future discussion.
Thank you so much for bringing that up, Jamie. Next, we have Sabrina Petrell.
Hi, good morning or good afternoon now, Chair Shell. My name is Sabrina Petrell. I'm here on behalf of Boys Town. I just wanted to clarify a comment made by Member Mandel at the beginning of the meeting. Boys Town has been in Nevada since 1991 and is still here, working statewide with children, families, and schools doing wraparound care. But after 49 years of research, Boys Town decided about a decade ago now to no longer have psychiatric residential treatment facilities in Nevada after Clark County changed their pay model. So just want to clarify, Boys Town is very much still active in Nevada, statewide. Happy to connect any members that have questions with the Boys Town Executive Director, John Etzel. Thanks.
Thank you so much for being here, Sabrina. Anyone else wishing to make public comment? Okay, that will conclude public comment for today. Just as a reminder to our subcommittee members, we do have our full SURG meeting in April, and then we will come back as a subcommittee in May to meet. Just know we will be taking these 5 recommendations we discussed today to the full SURG, but just know that the full SURG could have questions or recommendations for us to consider that we will then take up at our May meeting, and at that time finalize those recommendations to then go back to the SURG in June. So anything I left out there, Kim? Any other?
No, I would just ask for guidance from the group for the next agenda if they would like to continue review of the recommendations that were offered. We would traditionally, the ones that Dr. Partita Corona had provided, we will, as I noted, put those up on the SURG website so the public can see those, and then we will also share them with the subcommittee members in advance of the May meeting. So that would be our standard process, and I just want to test it with you, Chair Shell, given the timing of where we are.
Yeah, I think it would be helpful to go through those at the May meeting, knowing that we'll have to they won't make it into this current report cycle, but I think it would still be helpful for the rest of our subcommittee to know the great recommendations that Dr. Perdita Corona has brought forward, and that we can then continue to further flesh out and refine if necessary in anticipation of the next report cycle. If the rest of the group is okay with that. Is anyone opposed to that?
No.
Okay. Thank you all again for being here today. I again sincerely apologize. We ran way over. I think I was mixing up the 2-hour time duration for the full SURG meeting, so I apologize. But thank you all for being here. We'll see you at the full SURG in April and then at our next subcommittee meeting in May. Everyone have a great day. Thank you all.
Thank you. Bye.
Thank you.